I'm Dr. Chethan Rao, and then I'm excited to be talking to you about some non-invasive neuromonitoring and what kind of lessons we have learned from working with NASA. And as you see, most of my work is supported by funding from NASA and Center for Space Medicine that has helped in developing some of the interesting studies that I'll present. So the objectives today are to kind of delineate what kind of physiological challenges and what are the resultant phenotypes of spaceflight associated neuroocular syndrome, or SANS. And how have we created terrestrial models to mimic that? And then what kind of non-invasive technology have we used? And then how can they be helpful in delineating this space-associated neurological dysfunction? And finally, what are the critical care applications? How can we apply to neurological patients with serious disorders? And let's start with challenges about spaceflight. We take a lot of things granted when we are on Earth. However, in spaceflight, the physiology changes significantly. It also depends on whether there is a short or a long duration spaceflight. In short duration microgravity missions, there is cerebral shift of fluids, which causes nasal congestion and sinus congestion and headache. There are some neurovestibular changes that causes uncontrolled nausea and vomiting. There's obviously back pain and some anxiety associated with short-term flights. Long-term flights is where more trouble creeps in. There is a space-associated neuroocular syndrome. I'll describe the phenotype in a bit. There is orthostatic symptoms, especially after re-entrance. There is going to be pooling of blood in the peripheries, which the body is not accustomed to, and then the astronauts feel a lot more woozier. Because of microgravity, there is loss of bone mineral density, causes nephrolithiasis, radiation-induced changes, and finally, chronic muscle deconditioning if you're in long-term space missions. Now, the medical challenges we face are more so in the lunar missions, and then will be even so more when we are considering the planetary missions, especially when we are trying a trip to Mars or another temporary landing station in the lunar space. So what is SANS? SANS is a constellation of ocular and neurological syndrome that's associated with long-term space flights. This has been noted for a while, but it was not too far ago that astronauts started complaining visual changes. The first thing they notice is a hyperoptic shift, which is because of the change in the viscosity of the lens in microgravity. And then they have to actually pack diopter plus two or plus 4 diopter lenses to help them fit into this new normal of their lenticular shapes. But there is something more severe to that. About 50% of all astronauts have recorded long-lasting ocular findings, and then one of whom is currently demonstrated in this picture. In this particular astronaut, this study was done 26 days post mission completion and 90 days post return to Earth, which pretty much showed optic cupping as seen in this in the nasal component. And there is some development of some choroidal folds. And when you look at an OCT taken at these specific angular cuts, the optical coherence tomography, which is like a CAT scan for the eyes, pretty much shows that there is retinal fiber thickening in the eye. And these are serious complications that can result in changes in vision, which can be permanent at times. So what are the typical SANS phenotype of the astronauts. Typically, these astronauts are seen in, these changes are seen in astronauts who have long duration flights. About 160 days is the average flight, and then the age is hardly any different between the two. And when you look at the MRI data post-flight, there are interestingly increased findings that is demonstrated. And this is a study that looked at about 34 astronauts, 18 of whom had long duration missions, and then 16 of whom had short duration missions. And in this particular imaging study, what you see is that with the space duration flight, there is an upward shift of the cerebellar tonsils. As you can see in this image, the cerebellum looks to be shifted up. And the same thing is seen in the sagittal view, where there is loss of CSF space more towards the cranium, and there is almost a complete cephalad shift of the cranium. And the same CSF space is also lost around the sagittal sinus, causing some venous compression. And finally, when you're looking at the ventricular sizes, they tend to be a little bit more wider. And then there is also a stretch in the optic chiasm on the imaging studies, as seen in the next image. And these are overlays of pre and post imaging. And then there is also enlargement of the ventricles. So there seems to be a little bit more of a CSF space within the intracranial system. And now, as seen in this particular axial cut as well. So this particular imaging study is reminding of somebody with an idiopathic intracranial hypertension. However, that's not the entire complete story, right? So when we look at, is this the same problem with the US astronauts? Even the cosmonauts reported similar problems, but however, their numbers were low, only 10. The average space mission was 160 days, similar to what the US astronauts had. And then they noted interesting findings in where the change in the CSF and the brain volumes were noted. The CSF decreased obviously in the cranial vault, which was as anticipated compared to what the US astronauts went to. There is increased CSF spaces in the ventricles, and there is interestingly reduced gray matter volume. But the good news is that the gray matter volume was able to recover over a period of time. And then, however, the increase in the CSF volume overall was seen not only in the surface, but also in the basilar cisterns of the cranial space. So what causes this? There were specifically two separate entities that are thought to be responsible for the SANS, and the major ones are either it's related to microgravity. And what does microgravity do? It causes a cephalad fluid shift, which causes because of removal of the physiological pressure gradients, increases intracranial blood volume, reduces CSF absorption, increases CSF volume, and causes increased venous pressure. That can result in increase in intraocular pressure and choroidal folds and hyperoptic shift. Now, the second reason why astronauts tend to have the SANS is thought to be related to higher ambient carbon dioxide. The average concentration of carbon dioxide in the International Space Station is about 0.5%, which is about 12 times as high as 0.04% of carbon dioxide we breathe on room air. So this can cause increased cerebral blood flow, increased cerebral intracranial blood volume, which can result in intracranial pressure increase, and then distension of the optic nerve, causing the disc edema, cottonwool spots, and other pathological changes associated with the SANS phenotype. So based on these suspected etiology, the realistically what we can measure is brain volume, cerebral blood volume, CSF dynamics, and if possible, ICP. Now there's a challenge to that. Space flight is challenging. If you look at the number of launches that has happened since 2010, we've had more than 50 launches last year, which is fantastic. But at the same time, for every kilogram payload of you spend anywhere between $100,000, $1 million to half $54,000 to $55,000 based on which mission you are utilizing. However, if these space flights are becoming more common, the cost with using a Falcon Heavy rocket might be brought down to $1,400. In other words, we might be in fact able to fly some heavier equipment to measure intracranial physiology. But there is a caveat to that. Even if we were to ship an MRI to International Space Station, you won't be able to deal with the magnetism, the effect it will have because of its motion of the magnets related to the orbit of the space station to be able to conduct all those experiments. So there are several limitations that preclude the use of conventional diagnostic studies, and then that's when we get innovative, and that's where we use non-invasive neurological techniques. Now, the other thing to do is, why don't we bring space to Earth? In other words, what are the terrestrial analogs of space flight we can develop within our constraints? Now, one of the things that is very conducive to mimic cerebral physiology in space is a head down tilt position, where pretty much you put on a flat surface and then tilt the person down as high as it's been done, as high as 20 or 24 degrees, but sustainably for a long period of time, up to 317 days, you can put patients, subjects in head down tilt position at -6 degrees or so. And that seems to be the most effective. What we did, our team did, was to conduct a prospective study looking at a terrestrial model, by looking to create a terrestrial model, by not only creating a head down tilt position, but by exposing the subjects to an elevated CO2 in the ambient air. And we conducted this study in Germany, in NVHAB, in the auspices of European Space Agency and the German Space Agency. The construct of the study involved baseline measurements followed by exposure to head down tilt for about a day, and then we would create a washout period, and then you would bring them back, baseline measurement, and then repeat the experiment. Now, we were blinded, as in the investigators were blinded to whether the subjects were exposed to high level of concentration of carbon dioxide or not. We wouldn't know. And then that created interesting observations. The things we used were TCDs, NIRS, Vitamed, non-invasive ICP, MRIs, WIPs, and some of which I'm going to describe to you as we go through this study. So to start with, we had to measure non-invasive ICP, for which we used a Vitamed device, and this is one of our subjects wearing this non-invasive intracranial pressure monitor. This particular monitor, what it does is it isolates the signals from TCD signals from an ophthalmic artery, and then puts external pressure through a cuff. And then that pressure matches the extracranial to the intracranial system, and using an algorithm, they calculate the intracranial pressure. Now, we did a separate experiment measuring the intracranial pressures with the device and comparing it with a lumbar puncture in patients with idiopathic intracranial hypertension. And that data pretty much shows that there is a comparable linear correlation between the two measurements with good replication. And what we did was we used the NIRS data. The NIRS data was interesting because during the NIRS device, pretty much as you know, the concept is that with vasodilation, there is increased conduction of heat, and that causes the NIR signal to change. What we did was we had NIRS device applied from the head to shoulder to knees. I mean, we called it the head, shoulder, knees, toes application, where we created, looked at the delta of the signal change from the head to the other regions. And we found some interesting findings there. Well, we anticipated that the head down tilt would cause some vasodilation, but it didn't. The carbon dioxide, however, caused significant vasodilation in the cranial space. By measuring the intracranial pressure, we noticed that the intracranial pressure doesn't change overall, irrespective of whether the patient is on head down tilt with or without carbon dioxide. Intraocular pressures had a different story. With increased carbon dioxide intake, or in patients who were exposed to, and subjects who were exposed to carbon dioxide, we noticed that the intraocular pressures were consistently elevated. And then for some reason, the right eye had a higher level compared to left. So these are non-invasive measures. We have to have some sort of a gold standard to compare our assessment. And for that, we used different MRI techniques. And then specifically, the one we were interested was a CSF pulsatility at the third ventricle. And then we tried to correlate with ICPs and NIRS devices. So then these are, we not only did we measure the different different positions of the patients, we wanted to make sure that the head angle was appropriate. And this is a representation of the MRI showing non-significant changes in the angle of the position of the head pre and post exposure to carbon dioxide across studies and different in the same patient. Now, what did we note in the MRI? We noted that subjects who were exposed to 3% carbon dioxide they had elevated cerebral arterial pressures. That was calculated and depend on the pulsatility seen on the MRI. They had increase in the interventricular CSF volume, which was also as a result of an increase in the intracranial resistivity index, and also increased the trans third ventricular flow of the CSF. And that was an interesting finding. And then we tried to also measure their cognitive performance testing. And then using a standard battery of cognitive performance, what we did find was that exposure to head down tilt alone did not result in significant differences between cognitive testing. However, carbon dioxide exposure caused decrease in response time. In other words, subjects were fast to respond. However, they had less accuracy of response when they were exposed to hypercarbia. But that was not it. We had to come up with some additional explanation as to why we are having these observations. What we ended up using another device, which is still under development. This is called the VIPS, or volumetric integral phase shift spectroscopy. The construct of this device is associated with electromagnetic induction, and there is a transmitter that scans out 0 to 400 megahertz, around the same wavelength as your cell phone, and the receiver looks at the phase shifts of those waves, and then the first iteration of the device is shown in this picture, and then eventually it improved to a very compact form. So the transmitter sends out transcranially, the receiver looks at the waveform. If there is a change in pathology or change in the volume in the intracranial space of individual components, the morphology of the wave changes. And that is picked up by the device. Now, using the same study, obviously, in all the patients, the data on the left, we developed an algorithm to look at the brain volume, or the brain DDEX, and found that it was obviously the blood volume increased when they were exposed to 3% CO2. And then finally, when we split those subjects between subjects who were exposed to 0.5% versus who were at the ambient, we had a very interesting observation. Subjects who were exposed to 0.5% carbon dioxide did not have the same robust vasodilatory findings as subjects who were not exposed to CO2. It was almost, it looked almost like pre-exposure to small amount of CO2 was actually protective for this subjects. So we did clarify that with imaging correlates, and then looking at the pulsatility index and also the resistive indices, we were able to find the same finding with the MRI as well. So how do we apply to bedside? And then specifically for this device, the WIPS device, I did a study looking at patients who are undergoing dialysis. What happens in patients is pretty much they are pre-dialysis, they are hyper-oncotic, and then they're volume overloaded. What dialysis does is remove the osmolar, remove the extracellular osmolar solution, and then that creates intracranial space to be relatively hyperosmolar, and then that results in cerebral edema. Whether it's when it's severe, it can result in herniation and brain death. However, when it's not, we call it dialysis disequilibrium syndrome. So the hypothesis was this occurs on a routine dialysis in all patients. And what we did was to measure the pre and post serum and measured and calculated osmolarity, and on 2 different intervals on the same week, on either Monday or Wednesday or Tuesday or Thursday. And I published the study in the Neurocritical Care Journal in 2017. We had an interesting observation. In this particular graph, this is a relative graph that shows an increase in the edema index as detected by the device. So you have a development of edema subclinically, but the device is able to pick up over the course of dialysis. Now, the question is, how do we know whether whatever that is measuring is edema or not? I did not have, the study was not funded to look at imaging studies. However, correlation with pre and post serum sodium showed that there is a linear correlation, and the R square was significant. And we came to a conclusion that this change we see resulting in the device was actually related to a change in the brain volume, or the creation of the presence of edema in dialysis patient. And then we are still in the process of evaluating this for other clinical application in the ICU. However, we have another the other exciting project that we just finished and then we're evaluating is using centrifuge as a countermeasure for the development of SANS. In other words, is it feasible to drive the cranial fluids towards caudal area? And then this is a centrifuge in the same NVHAB facility, and there's a subject who is sitting, who's been down on the centrifuge table. The centrifuge is turning on. As you see, the subject is holding an internal jugular vein probe, looking at the volumetric changes of jugular vein in real time, while there is Near's probe in there in the cranium. And also there is a PCD device hooked up there, along with the presence, along with a TCD device, and then there is a Near's device, and then sometimes we also use a Cerebrotech device in an effort to capture the real-time changes in cerebral hemodynamics in these patients. And furthermore, I'm also excited to report that we also have a prospective registry where we are looking at commercial astronaut flying into space, Traditionally, we've been evaluating astronauts who are trained, who are career flight surgeons, and then at the pinnacle of their health when they fly. But what happens to a civilian when a civilian crew when they take space partake space missions? And we just got funded through the Translational Research Institute of Space Health, looking at developing a prospective data registry of both physiological, the biological, and the genetic data available from all these subjects who are flying into space. And the first data collection completed with the Inspiration 4 mission. The next mission is a Japanese mission going through, following which there's Blue Origin's and Lockheed Martin's related space flights that we will be collecting data from. And these are some exciting studies we want to involve ourselves in, and which we will have more data, and kind of helps us to use the non-invasive neuromonitoring in understanding and unraveling the cerebral physiology. So what have we learned from NASA? Well, unraveling spaceflight is inspiring. The physiology has to be deciphered by development of novel non-invasive monitoring. And then these novel neuromonitors have potentially real-world clinical applications. And then finally, we were able to bring space to Earth. We were able to create a terrestrial model, which one of the subjects who was eventually developed retinal folds, early signs of papilledema, and the study was terminated. So this creates us to a unique opportunity for us to study space physiology on Earth. And with the help of non-invasive neuromonitors, hopefully we'll be able to come up with an effective countermeasure. And then this is not a single person's work. The PI on most of these studies is my colleague, Eric Burchard. You can recognize some familiar names here, Dr. Suarez, and this is the team in DLR, and a bunch of other colleagues who have helped with this study. And then I will take questions at the end of the talk, and then I thank you for your attention.